Hi, everyone. Thank you so much for such a terrific day filled with fantastic talks and lots of exciting information from all of our families, researchers, and clinicians. Now we're all back together for our Ask Me Anything session. But first, we're going to have a presentation from Heather, who's going to talk about her son, Maximilian, who has a GRIA4 variant. She had some technical difficulties in the past session for the breakout, so we're going to go ahead and allow her to present now.
Super. Thank you so much. So this is Maximilian, and as mentioned, he has a GRIA4 variant. And he's one of 6 known cases, emphasis on the one. We've tried for a few years, and we haven't been able to find any other GRIA4 families, but we're still looking, and hopefully we will. This is the family. Max has 2 older brothers. It's my husband, Fabian, and myself. And we've not managed to get one picture of ourselves together in the last year, which is quite remarkable. A little bit about Maximilian's story. He was born in Toronto in 2011, and really nothing out of the ordinary in pregnancy, birth, or really the first 12 months. The only thing looking back that was a bit of a clue is that he wasn't hitting his developmental milestones at the same time as his brothers did, but it was nothing to be really concerned about. It was really 12 to 24 months when everything changed for us. Just after Max turned 1, our family happened to move to Germany, and we would not have done that if we knew what was coming. So we really didn't suspect that anything was up. But after our move, 3 things happened. So one, Max started having a lot of seizures, and by the time he was 1.5, he was diagnosed with epilepsy and started on medication to control that. At the same time, those missed developmental milestones were becoming a bit of a concern, and we were starting therapies. And it was also the beginning of our journey to try and find out what was causing this. Let me just forward. So when Max was 2 to 5, he was on medication for seizures, and they definitely reduced in frequency. We continued with therapies to help treat his delays, but really the gap was quite large. He wasn't verbal, but he was very interested in communicating. And just before he turned 2 was when he took his first steps. And we were also still, trying to find out what was this. It was kind of a bit of a process of elimination for some more serious disorders. And then we had an unusual result related to a very serious disorder. And even though everyone was very sure, or kept saying he probably doesn't have this, not knowing what it was really fueled our need to figure out what it was. And that started on our path to sequencing. And then it was in late 2016 when we got the results from our sequencing, and Max didn't have any known diseases, but he had this variant in GRIA4. And at that time, Dr. Lemke had found 4 other similar cases. I think, 2 were kind of more severe, maybe 2 were less severe. So it didn't answer our, big questions of, will Max ever, blah, 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 what does this mean? But definitely knowing what he had was tremendously comforting. And if we fast forward for the last, few years, he's still on valproate. His seizures are still under control, which is great. Gross motor development, I'd say that's his steepest curve. He's become a very confident climber. He just learned to pedal a tricycle. And that has its own sort of supervision and safety challenges for us. Cognitively and communication-wise, he's learning, but very slowly, mostly nonverbal. And I think it's his report card from last year that really sums it up best. He needs intensive support with all aspects of daily life. We also now need to sort of manage the behavioral stuff that comes with a very big, strong boy. when he isn't understood or doesn't understand or doesn't get what he wants. And the tantrums today are nothing. The toddler tantrums are nothing compared to, some of the challenges today. We tried the medically supervised keto diet, and I was kind of hoping that might bring about some, major transformation. It's hard to measure, what was the benefit of the diet versus development and measure that. But I do feel like it helped him. And so even today, he's still on modified Atkins diet. And what we see in terms of kind of focus and behavior is worth the effort of having him on a specialized diet. And that takes us to where we were 3 months ago. So doing everything that we can to help Max with the way his brain functions, but we weren't really doing anything to address the root cause or to, find a treatment or cure. And that's when we reached out to Dr. Lemke to find out, what could we do and maybe who could do this. And he connected us to Cure Grin. And he pointed out, like, even within GRIA, there are similarities across all of the genes as well as the other ones. Grin, Grid, and Grick. So today, it feels like we're in a different place. From that connection to, really amazing things happened. The first is we got an understanding of what is that research path. So, the question that we wanted to know, it was wonderful. It's the same path, the same way that you would approach Grin. And then the other thing is around, that first, is it gain of function or loss of function? And we were able to find out, Dr. Traynelis was able to tell us from his past research that Max definitely has gain of function. And that was really interesting because there is, we were also told about an existing epilepsy drug that might be really helpful in a GRIA case that is gain of function. And we're now talking with our neurologist about testing that drug. And the second really great thing that happened, and this one I didn't really appreciate until I experienced it, was becoming one of many, with the emphasis on many. It's just amazing not to be this one rare variant, but to really be at this conference, to listen to other stories, and to be part of something much bigger. So that's our story about Max.
Terrific. Thank you so much for sharing, Heather. So I guess now we'll go ahead and get our Ask Me Anything session underway. For this session, we're joined by Keith McArthur, Dr. Tim Benke, Dr. Stephen Traynelis, Dr. Amy Ramsey, and Dr. Angelis Garcia Cazorla. And I am going to be serving as the moderator for this session. Again, my name is Meagan Collins, and I'm the research coordinator for Cure Grin. We'll be answering questions, as many questions as we can, from the Q&A box. So we remind you to refer to that and try to input your questions there. And then we'll also try to address any unanswered questions from previous sessions. And as a gentle reminder, we ask that all of our participants refrain from asking individual medical advice related questions, as our panelists will be unable to provide specific answers for those types of questions, but we're happy to address any general questions. And with that being said, thank you again for joining us, and we'll get started with what we already have in the Q&A. So the first question we have was stolen from another participant. If there are two kids with the exact same Grin variant, why do they present differently? So whoever wants to take a stab at that.
So we know that in other genetic diseases where you have cohorts of patients, even hundreds of patients, and the example I'll give to you is Rett syndrome. You'll have 100 patients. They all have exactly the same alteration in a specific gene, and yet there's a wide variability in what they look like. Well, there's all of these other things that interact in every single individual that influence what you look like. Your brown eyes versus blue eyes. It's all of these other genetic factors that are going to make you look just a little bit different. And those are a lot of the things that we don't understand. That, again, through collecting a lot of patients, hopefully we can understand, say for one particular change, we can understand what the range is. it's helpful for us as clinicians if we understand the range, then we can counsel families a lot better and not say that, well, this is exactly how it's going to be. I mean, we really just have to say, I don't know.
Great, thank you for that. So our next question is, are Grin children more susceptible to COVID-19 complications?
I'm going to say that that's a question for those people that are following this on Facebook. You know, unless that I haven't seen any reports in the literature. I've been trying to keep my eyes and ears to Facebook to hear about our patients with different neurodevelopmental disorders, about how well they've done. But I think that so far, I haven't heard of any one particular patient doing worse than another. You know, my concern is that I don't want our Grin patients to get COVID-19 because I'm concerned that they have a lot of other health issues with, you know, how they are able to manage their secretions and swallow. And so my concern that any sort of illness, like the flu even, that they might have a hard time with that. So I think we need to do whatever we can to protect our children so that they don't get COVID.
Great, thank you for that answer, Dr. Benke. So our next question is regarding problems with visual processing and visual memory. Are there specialists that work with that kind of problem, like speech and language therapists that work with language? It says that they don't necessarily know where to look for help or therapies because they live in Iceland.
Well, in general, neuropsychologists that are specialized in children should be aware of this kind of difficulties and even delineate appropriate programs for rehabilitation. So, yeah, this is a common problem in child neurology. Many other genetic and non-genetic diseases have this kind of difficulties.
Perfect. So our next question is, could the dopaminergic pathway be associated with some of the symptoms we see in our Grin kids?
If I could answer this, we've looked at this in mice, and it looks like there's indications that dopamine neurons are more active, but also that there might be some loss of dopamine neurons. So the volume of the part of the brain where the dopamine neurons reside is smaller. So it looks like developmentally there might be fewer dopamine neurons that are being made. But in terms of their activity, there's more firing that's going on. So their behaviors are consistent with too much dopamine. And this is when the NMDA receptors are not active enough. And so there are drugs that could be used that would attenuate dopamine and could be beneficial for some of the motor symptoms, not necessarily the hypotonia, but more the hyperkinetic when they're moving too much or have repetitive movements that could be modulated, at least it is in mice, with drugs that act on the dopamine system. However, you know, one of the parents brought up the idea that the reflux, does that have something to do with the dopamine system? And indeed, there are some dopamine antagonists that work on, you know, reducing the vomiting, or the acid reflux. So that is a possibility that I had not considered, and I really don't know how the peripheral dopamine system is affected. So I think that that's an open question. But some of the motor symptoms, particularly the hyperkinesis, that would be consistent with too much dopamine activity. Now, for the gain of function, I have no answers for that yet.
Okay, so our next question is related to the ketogenic diet, so also for you, Dr. Ramsey. A person in the panel asked if the ketogenic diet is only useful for treating epilepsy.
So this is a great question. And since there's some clinicians here, I don't know that I'm necessarily the best person. So, but when I was doing my research, there was a study where they showed that the ketogenic diet, even if it didn't reduce the seizure severity, it did have some improvements in terms of other cognitive and behavioral domains. So I didn't read that paper, but it was in the review that I mentioned in my recording, the Frontiers in Neuroscience review. So there is at least one paper where they reported that clinically, but I'm sure that the physicians in the room would have more to say on that than me. So.
Yeah, well, in fact, ketogenic diet initially was the more common use was epilepsy, to treat epilepsy, refractory epilepsy. But over time, the indications of ketogenic diet have grown. In particular, in adult neurologists, it is used for even for neurodegenerative conditions. So it has been, published to have a benefit in different type of problems in children. So it is still used first of all for epilepsy, but then there are some particular disorders where the ketogenic diet is the main treatment, like in the deficit of glucose transported into the brain, because you are using ketones instead of glucose as the main fuel of the brain. But it has also some kind of neuroprotective properties. So at least in our place, where we are starting to use it very early in patients with different neurodevelopmental problems, that we don't have any kind of contraindication, because you have to, to see if the disease that has the child has some kind of, interaction or problem with a ketogenic diet. So apparently it can have more effects that not only as an anti-seizure treatment. Yes.
So at the moment in pediatrics, it's we like to use it for medically refractory epilepsy. That means if you've been failed by at least 2 medications. There is another metabolic disorder where it's used. It's a disorder where the body is not able to transport glucose across the blood-brain barrier, so it's used there as well. One of the things to think about is when we use that sort of ketogenic diet, it's something that we bring patients into the hospital for, because it's a bit of a shock to the system. There are milder forms of the ketogenic diet, such as the modified Atkins diet, that is something that you could try on your own. But again, I wouldn't think about trying to do the ketogenic diet on your own unless it's part of a lot of help and assistance from your clinicians and dietitians.
Great, thank you for those answers. So it looks like we have a question related to registering a particular variant. So this person says that their child has a Grin 2B mutation, and they wanted to know how and where could they register and look up into some kind of database to explore different treatment options, if applicable, and to see if there are gain of function or loss of function variants, and be able to get in contact with potentially other individuals with that same variant.
So I can start with that. They can find information on the website, on the CFIRB website, as to whether or not there's functional data that exists, and that's pre-publication typically of all the variants, except right now some of the ones from Europe that we're working through. And that would at least let them know whether the work has already been done. That website would not allow them to find out who else might have that variant, and I don't really know how to direct them to that. That might be through parent groups, perhaps. In terms of registering, I would direct them to Tim's operation in Denver or Johannes, and that would be an entry path for us to eventually get that variant and work on it once they had actually enrolled in one of these registries. Tim, you want to add anything to that?
So I think the other part of the question is parents are wanting to go to the CFIRV website and determine if I'm gain or loss, and use this in order to make some treatment decisions. And I think that's still a very hypothetical notion, as I think a lot of people spoke about today. And I think we had a lot of insight actually provided from the work from the Collingridge lab about, what are our assumptions and are they true or not with regards to approaching these. And again, I would say that this really needs to be approached in terms of a structured and appropriate clinical trial, such that we absolutely have to determine safety, because it's not clear that these are safe or effective, the sorts of things that we're hypothetically proposing. So I know everybody wants to come up with a treatment. We wanted it the week before yesterday. But I think that we need to be careful here about how we approach this. And, our approach as a clinician is that we don't want to hurt anybody. And then the next thing is if we do a bunch of little trials this way, then if something's safe or effective, we will die by what gets posted on the internet. Somebody will have a good experience, somebody will have a bad experience, and we'll never really know who this could potentially help or even hurt. And I think that's really what we want to try to do. That's my opinion. I think that there are probably exceptions to this rule in certain cases, which we could talk about more.
Perfect. So we have another question about clinical trials. Are there any clinical trials with NAMs or PAMs in the near future?
Unlikely PAMs, positive allosteric modulators, just because technically by that definition, none have been clinically approved. And I don't know that any, apart from one, have progressed even to phase 1 trials. In terms of NAMs, negative allosteric modulators, which you might just broadly call inhibitors without implying any mechanism, I don't know of any trials, and it really goes back to the points Tim was making. We need to figure out just how to design that trial, how to fund that trial, who to include, what research data is appropriate that we have on which to base the trial design. And so that is I think a point for the future, and one everyone is anxious for, but there's no rushing it until we have a really solid idea, both in terms of the registry of how patients progress and a better idea how to stratify patients to figure out who's appropriate.
So, yeah, I think that when we design a trial, I think this is a perfect opportunity for a lot of family input. I would guess that we want to make not just your seizures better, we want to make your Grin disorder better. But we don't have a measure that says this is how bad your Grin disorder is here, and after we treat it, it's going to get better. And how we measure that, I mean, that's a big challenge that all of the disorders like the Grins are facing right now. There aren't reasonably accepted outcome measures that you could say, oh, that's the one that we'll use. We'll use a Bailey, we'll use a Vineland or something like that. And this is a big gap in the field.
Perfect. Thanks for that input. So our next question is there any mice model for Grin 2A or any medications being tried?
There are. Steve, you might. I think you might be able to speak to that better than I, because I think you've been collaborating with the labs that have made those, and maybe you made one.
Yeah, we have three models of Grin 2A we've worked on. Two of them made at the JAX lab in a collaboration with a large program grant, and Wayne Frankel was the driving force of that. Both of them were strong, unquestionable gain of function variants that drive the channel open all the time and keep it open with no ambiguity. And the work for one of those was published. The work from the other one was not published. But there is information out there. The publication is, Wayne Frankel is one of the authors. I'm an author, and Pedori is an author. And so that could easily be searched out. The third model we work on is a very simple model. It's just it's a Grin 2A knockout animal. It's an animal made many, many years ago in Japan by Shigetada Nakanishi, who simply wanted to understand what did Grin 2A do long before we knew there were variants in it. And so a typical way researchers do that is remove the gene and then study the microcircuitry, study the behavior. And we have had that in the lab. That animal shows hyperexcitability and altered seizure thresholds. And so in many ways, it's not a perfect, but a useful model of some of the loss of function variants. And we have not published on that, although there are a couple of publications from a French group, and Genentech, I believe, either has a publication or is writing something on that showing hyperexcitability. That animal has some pretty profound rearrangement in the order in which the different types of neurons come to be. And there's two broad classes: inhibitory, excitatory. The inhibitory dampen excitation, obviously from their name. And those have a very specific period at which those cells appear, migrate, and get connected. And in a very unexpected finding, it's it's dramatically altered in the Grin 2A. So we learned something already, that it changes that developmental profile. Amy, you have a lot of experience with also your Grin 1, and I think that's highly relevant here, where you have circuitry changes.
Yeah, it's I don't think we see as big of a change with the Grin 1 knockdown as what you're talking about with the Grin 2A. So that's actually remarkable. I don't think we see such a deficit in interneurons, although they're just based on looking at transcription profiles, we do see reductions in particularly somatostatin interneurons in the frontal cortex, and parvalbumin interneurons in the frontal cortex, but we've not really characterized it that carefully. And I think that our collaborator Evelyn Lamb and her group, they've started to look at EI balance in the mice, but I don't think it's as dramatic as what you're talking about for the Grin 2A. So I think it would be really interesting to compare our models.
I think another part of the question was treatments, and those animals are instructive at asking general research questions on whether a particular compound has an effect on the animal model. It gives a hint at the clinic, but the work that's been done on those animal models certainly does not yet predict or suggest a treatment. That one gain of function that's been published, the animals, the homozygous animals with 2 copies of the variant die at a very early age. And so that's an extreme model where you can ask whether certain NMDA antagonists, inhibitors, negative allosteric modulators prolong the life. And you can get a little bit of prolongation, but that hardly speaks to whether those would be the agents one would start thinking about.
Great. So we have a pretty specific question. A work published by Michael P. Sinek with the Grin 2B mutation demonstrated that the mutated proteins are not found in the cell membrane. It also demonstrated that if the number of receptors on the membrane is adequate, but in the presence of other proteins with the mutation, the functioning is not adequate. Probable intracellular toxicity due to protein degradation. Do you have any opinion on this work?
So I don't think I've read the particular paper, but it would not surprise me at all that there would be variants that would cause problems with NMDA receptor trafficking. And I think that that's probably been touched on. So I was listening to one of the sessions on the G620R mouse and their characterization. And we know that Catherine Roche has made a lot of variants in the C terminus where that will affect trafficking in the Grin 2 variants in the Grin 2 gene can affect trafficking. So I can't speak more about this, but I think that this is, we can classify these variants in terms of how they're affecting the biophysics, but then many of them are going to affect trafficking. Some of them are going to cause more receptor to be inserted. Some of them are going to cause less. So there's lots of different ways, but at the end of the day, we would need to find treatments that would address kind of the larger picture of, is this an overall gain of function or an overall loss of function? So we'll probably not be looking in terms of drug treatments at something that would be specific for any one variant. But I think if you were to try and do gene-based approaches, then that would be something that would be looked at many years down the road. But yeah.
Yeah, if I could just add a quick sentence to that. I also don't have that paper in working memory to comment on it, but I would agree that there are many deficits, particularly in Grin 2B, that can change trafficking. And we very often, not always, but often will do a very crude surface trafficking assay in a heterologous system. And many times outside of intracellular domains, we find variants in other domains that reduce the ability of that cell to move it to the surface. And we assume that the cell has many quality control systems, and when it manufactures anything, whether it's a Grin receptor or another protein, it has proteins that will touch that receptor and make sure that it looks and feels and is in the right shape. We call them chaperones. And if anything is wrong, it will target that for degradation. And so we've seen receptors that have problems with binding glutamate simply not go to the surface, similar with gating phenomenon. Grin 2B also seems to be have a very strong control of movement to the surface of anything it binds with. So a receptor that has one copy of 2A and one copy of 2B, 2B is the driver of that receptor to the membrane. So it wouldn't surprise me at all if that's the case.
Perfect. So we have a question about magnetic resonance therapy and TMS, and they wanted to know what you know about it and what your opinions are.
That's got to be one for the physicians, because
I'm
not going to talk about that.
As far as I know, there is no information regarding this kind of therapies in Grin patients. In other kind of disorders and GABA-related disorders, for instance, which is another neurotransmitter, we have some reports. Electric stimulation is also something that is like a common, not common, but more common practice every day regarding treatments, but there is no information so far. In any case, it should be really personalized. Like you have to have a map of the electrical activity of every patient. What do you want to apply this treatment for? I mean, is it for a particular objective, for a particular purpose, such as attention increase, or for even for epilepsy? In some cases, electrical stimulation is being used, but it is still in the field of clinical trials and not as a routine clinical practice. So I think we have to wait a little bit more to have more information and to use that in patients.
I agree.
Perfect. Thanks for that answer, you guys. So our next question is there any study on lifespan for Grin affected people? Is there any information out there about it?
I think that's one of the goals of the registries is we want to be able to address that question. It's one of the many questions we want to address. I think Dr. Lemke has some older patients in his registry. We do as well. Again, I think there's two issues here. A lot of our older patients have more difficulty with access to genetic testing. a lot of times when you graduate from the pediatric world, people aren't asking the question, why are you having these difficulties? And so testing isn't often offered in that sphere. So I would love to be able to have an opportunity to go into care homes and find a lot of our older patients so that we could answer this question, because I'm sure that a lot are there and they've been given a diagnosis like cerebral palsy or something else, and we've just missed them because they've been missed by the genetic revolution.
Great. Thank you for that answer, Dr. Benke. So our next question is, are there any Grin children who do not have epilepsy? If yes, then is there a possibility that they will be able to develop it later in their life? Can they just have epilepsy in their sleep, which is not noticed?
Great question. Yeah, not everybody has epilepsy, regardless of the Grin change. But again, we're trying to understand that more. Does it matter whether you're gain or loss, if that's true or not? But I think that we want to counsel families better by knowing this information that I think we'll pull from the registries. But seizures only in your sleep, I think that's something that's a specific question that you would discuss with your pediatric neurologist or neurologist to try to address that and why you might have that concern and how that would be addressed.
Great. So I think we've addressed most of the questions in the chat. So I'm going to go to some of the questions that were unanswered from some previous sessions. So it looks like one of the questions that was asked previously a couple of times are, what are the best papers to put forward to our medical teams?
I would say Johannes's papers. They've been the most comprehensive in cataloging patients with Grin changes. There are some others as well, but Johannes in his papers, he's got very detailed references, and so he's pulled in everybody. So they're very ecumenical in that regards. So those would probably be the most helpful. But again, a lot of clinicians have access to PubMed, and there's a feature on PubMed called Gene Reviews, and Dr. Lemke wrote the Gene Reviews piece on Grin disorders. So that's another good place for clinicians to direct your clinicians to.
Great. So we have another question for you, Dr. Benke. Could you explain autonomic storm?
No, I want Dr. Garcia to explain them. We can't explain them other than what we see is we think that it's an autonomic storm because we're seeing a lot of autonomic features. Now, the autonomic nervous system is that part of the nervous system that controls things that you can't control. It's how you breathe, it's your heart rate, it's sweating, it's your pupils, it's reflux, constipation, cold hands, cold feet, sweaty hands, sweaty feet. So it controls all of those things that you don't think about. And patients who are having these spells of, we talked about this in our session. There's a lot of movements, but we're also seeing that the patients, they're sweaty, their pupils are dilated, and it looks like their autonomic nervous system is not controlling things the way that it should. It does. It looks like it's, as we said, storming. And that's, I think, the best description that we have. And I think that it suggests that maybe there's some ways that we could think about trying to treat it. But again, I think that talking with your clinician about what those options might be, what's specifically going on in your family, I think is something that, is this something that you want to try to treat? Whatever it is, weighing the risk benefits for the side effects for that particular medicine, I think that's a good discussion with your clinician.
I have a question. Can I just ask, because this is fascinating to me too. Is this similar to what you see with Rett syndrome, where it's kind of like an overactive activation of the sympathetic that kind of doesn't calm down, or does it look more like an activation of the parasympathetic? When you say autonomic storm, or is it both of them happening? Does this look more like adrenaline or more like acetylcholine?
It's a mixture of both, and I think that's part of the issue of why it's difficult to treat. In Rett syndrome, at least, with my patients, I've tried everything, and I haven't found anything that works. But I think that the issue in Rett is probably very different from the issue in Grin, and it probably begs for more targeted treatments in both.
Okay, so we have a question. Have you ever tried IGF-1, insulin-like growth factor 1, or growth hormone to treat hypotonia or improve symptoms in patients with Grin disorders?
No, this kind of treatments, no.
No, I agree. That'd be experimental.
Yeah.
It could be the basis if there's some preclinical data, say from one of the animal models, that it's the sort of thing that might go towards a clinical trial. But I think that we want to know that and certainly the FDA and the EMA would want to know from a preclinical standpoint that it made a difference in one of those models first.
I know with the Grin knockdown that the serum levels of IGF-1 are changed. I can't remember whether it's up or down. I can look that up and see, but there probably, yes, there is some preclinical data that is changed in the serum of the mice, but beyond that, nothing's been done.
There is a clinical trial in Rett syndrome that's going on now that targets that signaling pathway. It's not with IGF-1, but it's a small molecule that's related to signaling in that pathway. But again, that trial happened because there was preclinical data.
Right. So we have a question about the significance of recent research into circadian rhythms related to Grin.
Well, I don't know what research they're referring to, but I would just comment that circadian rhythms are incredibly important. They dictate many features of how the central nervous system responds. They can cause problems when altered, and they can also dictate, as well as slower rhythms we're just learning about, the effectiveness of therapeutics. So I would think that's an important area to think about in general, and would hardly be one to dismiss. It seems like it could be highly relevant.
I also don't know the literature on that, on any kind of circadian rhythm, but I do know that the Grin knockdown mice are more active during what would be their sleep cycle. So they have measured the activity of the mice 24 hours a day, and they do show hyperactivity not just during their waking time, but also during the time when their litter mates are sleeping. They're up and about. So they do have sleep disturbances. The mice do, and that's something that's been described anecdotally with the children as well. I don't know if that's made it into Dr. Lemke's description or not, but it would not surprise me that if we were to carefully look at circadian rhythm, we would see probably deficits in that regulation.
I just wanted to say, I know it's almost officially time's up, but since we started late, the closing will be really quick. If people are able to stay for another 5 minutes or so, we could take a couple more questions. What's next, Meagan?
Okay. All right. Moving on. Let's go back to some of the previously unanswered questions. Let's see. Do we know how many of our Grin kids suffer from non-epileptic events?
Not yet. Again, this is something that we hope with our upcoming papers with Dr. Lemke, Dr. Traynelis, Dr. Park, Bain to answer this question in the next year. We hope we have enough data so that we can start giving you some percentages about these types of spells.
Great. So we have another question. Lots of our Grin 1 kids have common features in addition to their neurological and GI or muscular issues. For example, smooth skin, low weight, lustrous hair. How can gene therapy or editing be sure to target only the cells that need amendment?
That's a great question. Gene therapy has so much promise, and there is good reason to be excited about it, but it's also quite a complex game when you begin to introduce a virus that has the capacity to modify DNA. One way would be, as had been done with some of the rare disorders, to try to introduce a vector carrying your payload, your DNA, only into the central nervous system and hope that it does not get out. That would minimize potential peripheral effects, but you really couldn't be certain until you do really careful work and ensure that that's the case. So I would think brain restricted genetic approaches have the promise of avoiding some of that, but I would also be cautious that many other things, and of course, the CNS has bring about modification in the periphery, and the peripheral tissue can respond to modification and remodel itself as well.
I think it's also really an open question about, it seems like neurons are really good at regulating the levels of NMDA receptors that it appropriately needs. But I'm not sure what would happen if you had a virus that was driving expression, for example, in other tissues, if those tissues would have the right mechanisms to control gene expression. So it really could be very tricky to do. If you were talking about a gene expression rather than a gene editing, I think both of them are really quite challenging in the nuts and bolts of it.
Great. So we'll move on. Is gain of function or loss of function related to specific Grin disorders, for example, Grin 2A, associated more to gain of function or loss of function?
So this broad categorization of gain or loss of function that we derive from electrical recordings from cells that express these modified receptors, really doesn't show a strong difference among the subunits. From the ones we've looked at, and we haven't looked at them all yet, and it's been a haphazard introduction to the variants. It's not as if we randomly sampled everything that's out there. It looks like there's more or less an equal number of gain and loss of function for 2A. For 2B, it looks like there tend to be more loss of function. But as we had discussed in the session, and I think as many of the parents in the audience will know, that distinction is not so clear, and it's an evolving distinction that changes as we gain more information. And you can assume something is a gain of function and then find out the surface localization is okay. You think it's a gain of function, but later we find out, well, actually it doesn't go to the synapse, and then we make a mouse model and gain even new insight. And so, it's an open question right now. They look pretty even in 2A. 2B may favor loss of function, but I wouldn't put my hat on that answer. I think it just takes time to figure it out. And it's just an emphasis on the need, to do this sort of work and get to the bottom of it, and then dovetail it with the registries that Tim, Johannes, and others are building.
Terrific. Thank you all for your input. So we have a couple of questions for Keith. One person asked, are we being hopeful for an in-person conference in the spring of 2021? Also, would you please consider such online conferences, not only in person, to make it more accessible globally?
Yes, thanks for the question. So I would, to give my honest assessment, I'm sort of less optimistic day by day about whether we'll be able to get together in person. If we're doing it in Boston, we're still at a place right now where most other countries can't travel into the U.S. And things are not getting better very quickly, if they are getting better. So we're hopeful, but we'll have to kind of wait and see, and we'll have to make a decision about whether we'll postpone the in-person meeting or try to do another virtual meeting then if we do need to delay. And yes, absolutely, for the in-person meeting, with the support that we've received from CZI, we're planning to really invest in making sure that it can be just as good an experience for people who can't make it in person as it is for those that are attending in person.
Perfect. Well, I think that's probably a good place to stop. A lot of the questions that we have left are very specific to individual patients. And so unfortunately, we won't be able to answer those, but we certainly advise that you discuss them with your clinician and medical team. And we thank you all so much for your participation. We thank our speakers so much, and thank you for being so engaged and involved today. And we'll all meet back together in the lobby.
Actually, I think we're just staying here, Megan. Yeah, we're not.
Okay.
Yeah.
We'll all stay.
Okay. So what a day. That's just been amazing. I'd love to hear in the chat what you guys thought of today, but I'm just overwhelmed. I really think of all of you, whether you're parents or researchers or clinicians, as part of my extended family, this second Grin family that I have, and I'm just so grateful to have all of you as part of it. I want to just thank everyone who participated today for giving up a Saturday to be here. I want to thank all of the presenters. I don't have time to mention them all because we had so many people presenting today, but thank you all so much again for giving up your Saturday to help Grin families and to help move forward the research. I want to thank Denise and the rest of the Cure Grin board, and also Meagan and Angie. And finally, I want to thank Calliope, Clarissa, and Amber for helping us put this all together and making it a great event. Just want to let everybody here know that for the next month, by logging into the same site, you'll be able to have access to all of the sessions, including those that you weren't able to see today or those you want to watch again. And then there's plans eventually to take that content, or much of that content, and put it on the Grin website, possibly on YouTube, and also to translate some of these sessions into other languages. There's a survey that everybody who's registered for the conference is going to receive. It should go out on Tuesday morning, I believe. So please let us fill out the survey. So let us know any feedback and what you liked and what you didn't like. It'll really help us for planning future sessions. And then just two final asks. These are things I mentioned at the start of the day. The first one is we're putting together this book, Stories of Grin, with stories from parents, and I mentioned earlier, researchers can be part of it too. But basically, it's sharing your personal family experience of your child, or what it's like to be a Grin parent, your experiences. We're going to be putting these all together in a book that we're going to sell through Amazon this holiday season. The deadline for submissions was yesterday, but we are still looking for more submissions, and so we've extended the deadline until the end of the month, the 30th. And then finally, if you enjoyed the session today, if you believe in what we're doing, in what the researchers are doing, we hope that you can help us out in November, where we're launching our second annual Count Me Grin campaign. We have had challenges. We were really hoping to expand our fundraising this year with in-person events like golf tournaments and galas, but obviously we haven't been able to do that. So we're really counting on you, to family members, and I know Amy joined us last year and helped us raise funds for Count Me Grin, So thanks to everyone who participated last year, but this year we're really looking for at least 100 families who will try to reach out to their broader networks to raise $2,500 US. And if we can get 100 people that can raise an average of $2,500, that'll be $250,000. That'll go a long way to helping us reach our goal and have a decent amount of money to invest in research when we bring you all our research priorities in the spring. So thanks to everyone. Really had a great day, and hope you did too. And we'll see you soon.